Good evening, everyone. My name is Yi, and I'm your host for Occupational Medicine Pearls podcast. Today, I would like to review lead, which is an important occupational hazard. Lead is a bluish or silvery gray metal that is obtained by smelting of ores containing lead sulfide or sulfate or carbonate ores. It is one of the oldest recognized occupational toxin. The Romans used it in the plumbing and wine sweetening. By the 19th century, lead palsy or painter's colic were well described in the workers. In the 20th century, we added battery manufacturing, smelting, pigments, and petroadditives. In the history or in the literature, there is a term called satinism or saturnine. It is a form of chronic lead toxicity caused by the accumulation of lead in the body, historically leading to symptoms like severe abdominal pain, anemia, neurological issues, and gout. There is a term called saturnine gout. It is a specific manifestation of chronic lead poisoning that causes renal insufficiency and joint issues, historically linking to the drinking the moonshine or the illicitly distilled drinks. What changed over time is not our understanding that lead is toxic. We already knew that for centuries. But we now know that there is no safe threshold. The regulatory shift that is done in the recent years, including 2018 amendments, reduce removing levels and testing thresholds, reflecting this changing evidence. In the workplace today, inorganic lead is encountered as dust or fume. In the battery manufacturing and recycling industries, foundries, radiator repair, indoor firing ranges, abrasive blasting of oil coatings, and various high-temperature processes. There are also sources of non-occupational exposure which we need to cover in the history taking. We can get lead from the environment, but it is mostly from man-made objects. So the exposure may occur through hobby like shooting and fishing. After the history lesson, we will go to health monitoring. Health monitoring is advised by work health and safety regulations, and that has to be conducted by a registered medical practitioner experienced in health monitoring. So let's classify this into baseline health assessment, counseling, and ongoing monitoring, aka health surveillance. Baseline health monitoring before starting lead risk work include collecting data about demographic, medical, and occupational history, physical examination, and baseline biological monitoring. We use blood lead level for that. Before we move on, we need to understand what is lead risk work, because there is specific definition for that. Lead risk work is work likely to cause blood lead level to exceed 5 microgram per deciliter for females of reproductive capacity or 20 microgram per deciliter for all other workers. Baseline work must be done before starting lead risk work and repeated 1 month after commencement. After this, we need to know someone is starting. What are we going to ask in the history taking? So history focus on the personal health issues, previous occupational aspect, and their vulnerabilities. So we need to ask in women of reproductive capacity about previous reproductive history, current pregnancy or breastfeeding, any history of neuropsychological issues, any blood or kidney disorders. Do they have hobbies like shooting, fishing, and do they smoke cigarettes or any taking or chelating agents for medication? In terms of susceptibility, lead competes with calcium and interfere with heme synthesis. So people who had anemia, chronic kidney disease, and pre-existing neuropathy are vulnerable to the effects of lead. We do not collect or perform pulmonary function testing such as spirometry routinely, but it might be needed if respiratory protection is required or inhalation exposure is significant. A worker needs to be able to work while wearing respiratory protection, so that aspect needs to be considered. Similar to other pre-employment medicals, we need to provide counseling to the workers. We need to tell and exchange information so that people know what they're getting into and what we expect them of to keep everyone safe. In that aspect, we need to cover about bioaccumulation and long half-life of lead in the human body, risk to reproductive health, pregnancy and breastfeeding, and personal hygiene. This is not just about how many times you shower in a week or month, I hope, and this is about how you conduct yourself in the workplace. How do you keep your clothing, your workspace clean? How do you keep your hands clean? We need to stress that eating, drinking, or smoking in the lead process area is not acceptable. For women planning pregnancy, recommendation is to aim for blood lead level well below 5 microgram per deciliter for at least a year prior to conception. This is a critical message to provide to the workers. Not just women, men, male workers should also be informed that exposure to lead may adversely affect their reproductive function. So both genders could be affected. So that covers initial pre-employment state. Before we move on to health surveillance, we need to understand how does lead interact with human body or pharmacokinetics. The primary occupational routes are inhalation and ingestion because they are the most effective. About 30 to 50% of inhaled lead is deposited in the respiratory tract, and GI absorption is highly variable, similar to anything else, influenced by fasting state, age, solubility, dietary calcium, and iron. Once absorbed, lead circulates in blood, mostly bound to erythrocytes. Only 2 to 5% of total body burden is in red cells at any given time, so very few. About 94% of total body burden in adults is stored in the bone. So this is a key point. When we do blood lead level reflects the recent exposure. Bone lead level, thank God that we don't do that, reflects cumulative exposure. Blood lead half-life is about 20 to 35 days after exposure. Red cell lifespan is about 120 days, so about 3 months. Bone redistribution can take up to 3 to 30 years. So that's a lot of years. And that may even be overall working time for some of the workers that we are helping. So when we remove someone from exposure and their blood lead level falls, that doesn't mean that their body burden is normalized. It just means that equilibrium has shifted. Repeated exposure lead to progressive accumulation, the same way as we studying for the exams. Chelation reduces circulating lead but doesn't necessarily reverse cognitive effects, unfortunately. This segment covered the aspects of pharmacokinetics. Afterwards, we will go to health monitoring and health surveillance. For most of the time, biological monitoring or blood is the primary method. Frequency really depends on the level and reproductive status. This is something we need to know by heart. If you wake up in the middle of the night, someone asks you these numbers, you need to know by heart. For males and females not of reproductive capacity, we have the frequency of testing is based on the level. So if their level is less than 10 microgram per deciliter, we do routine tests at 6 months. If the level is between 10 and 19, we test at 3 months. We probably should check what are their hobbies, what are the controls like, and if it is more than 20, we are really worried. We will be checking every 6 weeks. Now, this is not that we are checking blood tests and forgetting about everything else. We should be actively looking for why the level is more than 20. Similarly, for females with reproductive capacity, we follow similar time routine but at different level. If the level is less than 5 microgram per deciliter, we test at 3 months. If between 5 and 9 microgram per deciliter, we test at every 6 weeks. There is a removal threshold. The removal is mandatory if the level is more than 30 microgram per deciliter. That's for male and females not of reproductive capacity. And for females of reproductive capacity, that level is more than 10. So if you see someone and if they are able to have a child and their level is 11, we need to remove them from the work. So you see these numbers, this is not for a discussion, this is removal and we need to review the control. from the urine level is not that useful. We can also look at blood zinc protoporphyrin ZPP level. It reflects average exposure over 3 months but lags and has been low specificity. It may be considered once removal limits are reached, but it is not substitute for blood lead level. The workplace exposure standard is set at 0.05 mg per cubic meter TWA. In comparison, Latvia has 8-hour TWA of 0.005, so that's significantly lower than Australian limit. Level of TWA 0.05 does not mean it is protective for the workers. The lead level could still be 20 to 40 microgram per deciliter with that air monitoring level. So this is important to understand. Once a worker had been removed from work, a second medical examination must occur within 7 days, and return to work can be considered if the lead level is less than 20 microgram per deciliter for most workers, but for females of reproductive capacity, it has to be less than 5, and they should be clear of any health or ill health symptoms. Repeat testing after removal should occur every 3 to 6 weeks until level 4 appropriately. From occupational health perspective, this is where our advisory role is critical. Removal is a sign or signal of control failure. We should be advising engineering and hygiene review, not just retesting. After health surveillance, we should look at target organ effects. As mentioned before, primary method of exposure are inhalation and ingestion, and air monitoring alone may underestimate risk because hand-to-mouth ingestion can dominate. Surface contamination and hygiene behaviors are very important. Habits such as nail biting, smoking, or eating in the process area, they are dangerous. If you see a worker with rising blood level in a worker despite compliant air monitoring, we need to think about ingestion. Okay, target organ effects. Acute poisoning of lead is uncommon today in occupational setting. More commonly is that it is a chronic disease by gradual accumulation of a significant body burden. Nervous system is a primary target, although bone is the storage organ. When it is severe, it can cause encephalopathy and coma. Chronic high exposure can lead to peripheral neuropathy or lead palsy. But more likely, you will see people with fatigue, irritability, or subtle cognitive changes with the chronic low-level exposure. In the blood, we can see that lead can inhibit the synthesis of the blood cells, so it can cause anemia, and it can increase blood pressure, ECG changes, and renal dysfunction. It has negative effect on reproductive effects in both sexes. Lead distribute to all tissue but predominantly accumulate in bone, and skeletal reserve is the long-term risk. I did not mention about how it affects children because we are talking in the occupational setting and we don't normally hire kids in the employment. Based on the epidemiological data, we can see that spontaneous abortion and developmental delay can happen if the level is more than 5 microgram per deciliter. The same with hypertension and kidney dysfunction. Reduced birth weight and neurocognitive deficit can be seen if the level is more than 10. Neurocognitive effects, sperm abnormality, anemia, and gout can happen at more than 40. And encephalopathy may be seen if the level is more than 80. Now, this is non-occupational data. Chelation is generally considered from around 40 microgram per deciliter depending on the symptoms. Carcinogenicity. Lead itself is not regarded as carcinogenic, but lead compounds may be causing cancer, so we categorize it as category 2. Lead chromate and lead hydrogen arsenate are the suspects in this category. So from the practical perspective, we need to apply the ALARA or as low as reasonably achievable or possible in this setting. I also would like to cover briefly about occupational hygiene monitoring. We covered the workplace exposure standard. We can conduct air monitoring and surface sampling. Air monitoring for lead is achievable with the use of inhalable dust sampler. It is a common method for measuring lead particulate in the air, and AIOH also recommends personal sampling for determining the degree of health risks and compliance with the WES. Surface dust sampling can be achieved with wipe sampling, and it can be used to detect evidence of cross-contamination and to see whether the workplace hygiene practices are up to the standard. After measuring the level, I want to cover briefly about control. The most effective means of restricting inorganic lead uptake is by controlling the exposure, and we have to follow the hierarchy of controls to keep the workplace safe. We start with elimination if possible, of course, and that's why we stop using petrol and other products that has lead in there. We start at the workplaces. We look with provision of the improved enclosure and ventilation to capture fume and particulate matter, good housekeeping with emphasis on clean surfaces where there is hand-to-mouth contact, and we need to provide changing room and wash facility for good personal hygiene. Providing the facility itself is not adequate. The workers themselves need to wash themselves properly by taking enough time. A policy on not eating and smoking in the lead-contaminated area and other administrative control may include cleaning routines and limiting on the exposure time. Last bit is the protective clothing or PPE, and that has to cover the coverall, respiratory protection, and appropriate shoes and eye cover. So I'm going to close this episode now. Lead is one of the oldest occupational hazards, and it's still one of the most instructive here. If you are supervising a lead program, remember, every blood lead level is a data point in the long biological story. Your role is to interpret that story in the context of exposure controls, physiology, and long-term risks. I hope you find this episode useful. Until next time, bye.